Hey everyone, and welcome to this explainer. I am so thrilled you're joining me today because, honestly, we're about to unpack something absolutely fascinating. If you're like me, you love diving into the exacting precision required behind the scenes of healthcare. Well, today, our focus is entirely on the incredible hidden geometry of skull radiography. We're going to break down exactly how medical professionals capture the perfect image of the human cranium, specifically looking at two foundational techniques, the PA and the Caldwell method. So get ready to see the human head in a completely structured, three-dimensional way. Now, I want you to keep this one concept in the back of your mind as we go through our explainer today. A mere 15-degree shift changes everything. Just think about how complex and dense the anatomy of the human head is, right? It's literally a marvel of engineering. But what we're going to see today is how a tiny, almost imperceptible manipulation in physical space completely alters our view of that dense anatomy, allowing us to see exactly what we need for a precise diagnosis. Okay, let's dive right into this with Section 1, the art of skull radiography. You know, capturing a perfect view of the frontal bone isn't just about pointing a camera and clicking a button. It's truly an art form, and it's governed by some very strict geometric rules. To really ground ourselves in 3D space here, we need to define two absolutely critical anatomical landmarks right from our protocol: the orbitometal line and the nasion. Think of the nasion as your exact targeting bullseye. It's that little depression right at the bridge of the nose. And the orbitometal line, that's an invisible reference line running from the outer edge of the eye to the ear opening. So in setting up our image, the patient's neck flexes specifically to make this orbitometal line perfectly perpendicular to the image receptor, or the IR. Meanwhile, the central ray of our beam targets that nasion. These two spatial anchors basically dictate the entire geometry of the SOP. Moving on to Section 2, the PA projection setup. All right, now that we know our landmarks, we're going to start with our baseline, the standard PA, or posterior-anterior projection. That just means the beam travels from the back of the head to the front. Before the patient even moves into their final position, the baseline protocol requirements are set in stone. The collimation, the shaping of the beam, is set to a 10 by 12 vertical, ensuring there are 1-inch borders all around the skull. Our primary target here is the frontal bone of interest. The patient is positioned either prone, lying on their stomach, or seated upright in that PA orientation. And crucially, respiration must be suspended during exposure. Minimizing variables, like just having the patient hold their breath to prevent motion blur, is that very first, absolutely vital step to diagnostic clarity. Next, we have this sort of spatial mini-narrative of actually positioning the patient's anatomy against the image receptor. It's a really precise 4-step dance. Step 1, we center the mid-sagittal plane, that's the line dividing the left and right halves of the body, directly to the IR, making sure the shoulders are in the same horizontal plane. Step 2, the patient places their nose and forehead directly on the image receptor. Step 3, like we mentioned earlier, we flex the patient's neck so that the orbitometal line is perfectly perpendicular to the IR. And finally, Step 4, we center the patient's nasion right to the center of the IR. So once the patient is locked in, the beam is introduced. And here is the absolutely crucial point. The central ray, or CR, is directed exactly perpendicular to exit the nasion. That word, perpendicular, is the defining trait of the standard PA projection. There is absolutely no angle to the beam here. None. And to ensure perfect alignment, the protocol strictly dictates that both sides of the external acoustic meatus, the ear canals, must be exactly equidistant to the image receptor. Let's move to Section 3, evaluating the PA skull. Okay, so we've set it up, we've taken the image, but how do we know for sure if we successfully achieved a perfect, rotation-free shot? Well, we use a strict clinical checklist. For the image to be diagnostic, we absolutely must see the entire cranium without any rotation or tilt. We verify this by checking for symmetric indicators. We're looking for equal distances from the lateral borders of the skull to the lateral borders of the orbits on both sides. The mid-sagittal plane of the cranium has got to be perfectly aligned with the long axis of the collimated field. We also need to see the entire cranial perimeter showing 3 distinct tables of squamous bone. And finally, that nasal bone acts as a great indicator that absolutely no rotation has occurred. It's a rigorous checklist for sure. Now, what's really interesting about this next point is a very specific quote from the evaluation protocol. It says, PA projection shows orbits filled by pittrous ridges. Because our central ray was perfectly perpendicular, the dense, bony structures known as the pittrous ridges are projected straight forward. So the specific visual outcome of this perpendicular PA setup is that those thick pittrous ridges completely obscure the orbits. They just fill them up entirely on the resulting image. Which brings us to Section 4, the 15-degree Caldwell shift. But what if the doctor actually needs to see inside those orbits? What if those dense, petrous ridges are blocking the exact anatomy they are trying to evaluate? Well, this brings us to the plot twist of our explainer. I want to pose this directly to you. What happens if we change absolutely nothing about the patient's physical position, but angle the beam just 15 degrees? Just think about how a single manipulated variable might impact the final diagnostic image. 15. That is the magic number. In the Caldwell method, a 15-degree caudate angle, meaning it's angled downward toward the feet, is applied to the central ray. The beam still exits exactly at the nasion, but this 15-degree downward tilt is literally the sole physical difference in our setup. And I really want to emphasize this to save you from any redundant memorization. The patient setup is absolutely identical. 10 by 12 vertical collimation, prone or seated upright, mid-sagittal plane centered, nose and forehead resting on the IR, neck flexed to make the orbital medial line perpendicular. The baseline rules we established earlier still apply perfectly here. The patient doesn't move a muscle, only the machine moves. Let's move to Section 5 and see how this builds our understanding, comparing final outcomes. All right, let's map our two methods side by side to solve our spot the difference mystery. Contrasting the geometry directly, we have the PA skull central ray, which is perfectly perpendicular, exiting the nasion, versus the Caldwell central ray, which utilizes that downward 15-degree caudate angle, also exiting the nasion. This seemingly slight geometric shift is the absolute key to revealing completely different cranial structures. And this brilliantly illustrates the massive why it matters payoff. In our PA skull evaluation, remember, the orbits were completely filled and obscured by the petrous ridges. But look at the Caldwell evaluation. The PA axial demonstrates those dense petrous pyramids, or ridges, lying in the lower third of the orbit. That 15-degree angle dramatically drops those dense ridges down, effectively clearing the upper orbital view for the radiologist to evaluate. It's such an elegant mathematical solution to a biological obstacle. Let's bring it all together by noting that despite this dramatic, necessary shift of the anatomy inside the orbits, our strict baseline requirements remain exactly the same. Whether you're performing a straight PA or a 15-degree Caldwell, the final image must still demonstrate the entire cranium without rotation or tilt. You still must have symmetric petrous ridges, equal and equidistant lateral borders on both sides, and those 3 distinct tables of squamous bone around the entire cranial perimeter. A perfect, unrotated skull is just non-negotiable in both methods. As we wrap up this explainer, I'm going to leave you with this thought. How will you view the hidden geometry of the human body moving forward, knowing that a simple 15-degree shift alters our entire perspective? It really makes you marvel at the incredible, invisible precision utilized by medical imaging professionals every single day just to see right through us. Thank you so much for joining me to explore the structured art of skull radiography. Keep seeking out the structure in everything around you, and I'll catch you in the next explainer.